everyone. I'm Annalise Riles, and I'm the Executive Director of the Northwestern Buffett Institute for Global Affairs. And the mission of Northwestern Buffett is to bring perspectives from across the disciplines and around the world together to creatively and courageously address the greatest global challenges. And at the moment, we collectively face an astounding global challenge with the novel coronavirus. The crisis does make us aware of our common humanity and our global interconnectedness. And although we're all immersed in the crisis management associated with caring for our families and colleagues, and institutions and communities, we know that there is a need for more expansive thinking about what we're now facing. So during this trying time, we are honored to host an esteemed cultural anthropologist, Dr. Adia Benton, who will speak to us about COVID-19, including what we know and what we don't know about the virus and its transmission. Adia is Associate Professor of Anthropology here at Northwestern, where she studies patterns of inequality in the distribution of and politics of care, specifically during complex humanitarian emergencies like our current crisis. Her first book, HIV Exceptionalism, Development Through Disease in Sierra Leone, explores the treatment of AIDS and as an exception disease and assesses the recognition and care that designation takes away from other diseases and public health challenges in poor countries. Adia is also at work on projects about the 2013-2015 West Africa Ebola outbreak and global movements to improve access to quality surgical care. So Adia will address the roles of scientific and public health expertise in calibrating recommendations at various levels of government. And she will discuss different ways which we can reframe our conversations about approaches to flattening the curve, as we call it. So Adia, thank you so much for being here. We're all super excited to hear what you have to say. Over to you.
Thanks, Annalise. So, as you can imagine, this has been a trying few days, including I have lots of kids, some kids upstairs, so you might hear occasional noise. And it also meant that I didn't get to put together the beautiful slides that I wanted to put together, including one that had MC Hammer dancing to Can't Touch This. Can't touch it. So hopefully we won't be touching our faces throughout this thing. We'll be washing our hands. So I think I want to start with a brief overview of this outbreak. And hopefully we'll start questions maybe 20 to 25 minutes in, because I want to be able to engage as difficult as it is using this medium. But I'll start a little bit with what everyone I think already knows or should know, which is that novel coronavirus disease, or COVID-19, which is named that because it is a coronavirus that was discovered in 2019. The way we found out about this thing was through a series of cases that emerged in December of 2019 in Wuhan, China. Of course, scientists of varying stripes have been able to trace this back to at least as early as November 2019. The putative source or origin of this outbreak was a seafood market, but again, that is also contested because the people who sort of preceded this, what's known as the sort of biggest opening cluster of this outbreak, are people who had no contact with that seafood market. So fast forward to, we're in March. So we've had something like 5 to 6 months of this spreading from Wuhan and rapidly to multiple countries. I think we're in 100. I keep the dashboard for Johns Hopkins open. That's a really great resource for people who are interested. But 155 countries have now had infections. So a lot of people usually want to know, how do I know if I have this disease? Is that something people really, I wish people could hold hands, right? Yay. So some of the symptoms are, or at least the primary symptoms that we've heard of, are fever, cough, and shortness of breath. So you're not seeing a lot of runny noses, you're not seeing all of that stuff, but it feels like the flu, it looks a lot like the flu. What most people are concerned about is that there's sort of asymptomatic transmission. It is a droplet infection, which is to say it's not airborne. It's not to say that droplets do not move in the air, but it's not as easily transmissible as something like measles. So it doesn't hang in the air in ways that an airborne disease might. So you don't have to worry about it sort of lingering in the air for hours as you might think about for measles. It does mean, however, that surfaces that are not disinfected and cleaned are often the ways that people get this, or very close distance or proximity to a person who has been infected increases your risk of becoming infected with the disease. So that's sort of like the sort of way to talk about risk. As many of you know and have heard, there are certain people who are at great risk of becoming very sick from this disease. Most people, and that's like 70 to 80% of people, might have something like what's called a mild infection, which isn't to say that you won't feel bad, but it's to say that you might not require hospitalization. 15 to 20% might have experienced more serious conditions in which hospitalization looks like the appropriate thing. And they're saying something like 5%, and this is looking at the whole range of cases. Something like 5% of people might end up in the ICU, 1%. And again, you're going to hear a lot of variation on what case fatality rate is right now. Case fatality rate is not something you can definitively pin down in the middle of an outbreak, but you'll hear something between 1% and 3%, okay? Some of you, I'm trying to think, I'm just sort of talking through all of the facts, what we know. Most people, so to get back to this, who gets very sick, people with underlying conditions, irrespective of age, are very old people. So people who are 60, 70, 80, the mortality and the seriousness or severity of the disease is of heightened likelihood at those times. We also, people I know are also concerned about children, because we know that most of us who have small children, we also see them looking pretty sick all the time, including mine. He's had a runny nose for about 6 months. The conventional wisdom currently is that children are not necessarily driving transmission as they might in other situations. But I would suggest that we look at those data quite cautiously because of how households are structured. So in other words, a lot of transmission is actually very much about close proximity, and therefore homes are where a lot of the transmission is actually happening. Which is to say, you're close to people who are less than 6 feet away from someone for more than 10 minutes. I know many of you acknowledge that in your homes, you don't necessarily sanitize and disinfect everything all the time. And so when you have these sort of close interactions with people in your home, if one of you gets sick, most of you get sick. When my kids come home sick, I'm often like, oh, I'm sure in 3 or 4 days, I will have what they have, and it'll hit me harder. That's usually the case. So these are the kinds of questions or conversations that we have to be having about how we reduce the transmission. Let's see. I want to actually pause on the household transmission question, because I think this is actually where anthropology and demography might also contribute. So one of the things, I'm doing this from home. We're all doing this from home at this point. One of the things that concerns me about shutdown on this sort of flattening the curve level is that we are now, so if any of us have become infected in the past 5 to 7 days, we're now coming home and we're kind of localizing our infections. For those of us who live in multi-generational households, it might mean that we have to start thinking about how we isolate ourselves from our loved ones. We have to think about how our surfaces are, like how we interact with each other. How do you keep your 4-year-old, for example, or 3-year-old from hugging and kissing you all of the time? These are real questions and concerns. And so household structure, I would think, would matter as much as what you're doing outside of your home. So these are things I would love, if during Q&A, if people are interested in talking about that more, I'm happy to also address that. Because you're hearing about social distancing as the way that you're supposed to be able to fight this at home. we need to be thinking about what that actually means and entails, particularly for those of us who have family members who are in and out, who have to actually continue to work. I'm married to a person who's an essential worker who happens to know how to run an ICU. So how will that affect our household dynamics? I also happen to be in a circle or network of friends who have to drop kids off occasionally, and vice versa. So how do those social network questions actually impinge upon this idea of flattening the curve? So these are the things that I'm thinking about as an anthropologist. The other thing I'm thinking about is labor. So what becomes essential? Many of the people that I interact with on a daily basis are hourly workers, contract laborers, people who do not have the ability, do not have benefits, do not have the resources to carry on and to pay their bills. When Donald Trump and his economic advisory team put their plans together, how are we going to manage? How are our community members going to manage? I haven't voted yet. I'm going to vote today. These are the questions that I'm actually thinking about. I hope no one really asked me about hand washing, but I'll just leave that. We know that. Wash your hands. The tests. So one of the other things that I'm concerned about. So I'm sure most people are live in places where schools have been closed, and we're dealing with the blowback of that in a bunch of different ways. The city of Chicago has actually been planning for this outbreak. Well, there's been an emergency preparedness plan in the works for a while. I think they actually did a scenario exercise well before this outbreak happened. And so they had planned for the eventuality of closing schools, and therefore can distribute lunch. They also probably took a little bit longer than some people would have liked to close down schools. That said, I will come out as a person who has questioned this decision for a range of reasons. And a lot of that has to do with who provides care, who offers caregiving, what happens when the school is sort of a kernel or the beginning of, or at least a central node in a community. So what can it do and what can be done through those with respect to epidemics? That said, I'm also happy that we're able to implement a preparedness plan in a very quick way, and one that actually kind of links up to broader programs. We do not have enough testing, though. And that is a federal problem. That's a state problem. That's a county problem. So I'm hoping that someone will ask specifically about that. I have a whole list of things here, but I really feel like I want to be able to address people's questions. So the last thing I'll talk about for now is the question of flattening the curve. So there are two things that we've been hearing, the sort of big messages that we've been getting from our governments. And I'm using that loosely because I don't think that the message actually has been unified at all levels. But one of the things that we've been hearing a lot about is social distancing and flattening the curve. And so I'm assuming that most people know what that means, but I'm going to talk about what it means, and then what people who use it mean, and then what that actually might mean for us as people who are trying to kind of go about our lives with some semblance of normalcy. I don't know if that's really possible, but flattening the curve is what we've been sold. And so when we hear flattening the curve, what we're also hearing is what you're trying to do is trying to kind of manage the number of people who end up in the hospital. Make sure that there aren't, so that we don't max out our capacity to care for people who are seriously ill. And so what we're doing is we're kind of trying to make sure that rather than having that huge sort of growth of disease, we're going to have it sort of spread itself out so that capacity can match need. So in other words, when we limit our movement, we're limiting the spread, and then it sort of keeps us below hospital capacity. That's great. But as we know, so there are a lot of things that that concern me about the curve. So if you actually look at what are the X and Y axes, what do they mean? We mean number of infections, and we have that curve that is sort of, and then there's a hospital capacity, which is sort of the threshold that we're trying to meet or stay below. And there's time. What we're doing is we're extending time. We're lowering infections. And so in some ways what we're doing is we're localizing our infection. My question is, how do we think about that curve or in relation to region? So in other words, there's some regions that have higher numbers, higher density of people, different kinds of household structures. You have different regions that are underserved already. Right? So what happens if you live in a rural region where all of the hospitals consolidated and moved? What if you're in a place that has high population density, high rates of transmission amongst them, and so on and so forth? So we have to think about like what a flattened curve looks like in our sort of specific space. It's something I'm still trying to work through, but I'm trying to think of it as a social issue. So as an anthropologist, like can we translate the epidemiological and sort of clinical concerns into ones that acknowledge the social context and the political context and the economic context in which we're actually trying to do this collectively change the shape of that curve. So that's the way I'm talking about reframing. So I'm wondering if now we can, it's early for questions, but I'm wondering if we can shift to them because I probably have, people probably have a lot to ask since it looks like there are about 600 people here. I'm seeing some questions, but having trouble.
Hi, everyone. This is Ariel Schwartz, Associate Director for Research. Adia, I just want to direct you to your private messaging, and you'll be able to see the questions that I'm sending through to you there. We have one. The first question is about balancing the non-COVID-19 health risks of isolating our most vulnerable against the COVID-19 propagation risk. This is someone who's departing in a few minutes, so I wanted to push that question to the top.
Right, and that's actually something that I have wondered about. And honestly, if anyone's here looking for an NSF rapid grant, this might be one of them, which is I'm hoping that the question is about, or I'm reading this or understanding this question to mean what happens to everyone else who's sick with other things, people who have chronic conditions, for example, so diabetics, people who are hypertensive, people who have heart disease, whatever it is. So what happens when there are other people who need hospitalization for other things? What happens when are there people whose care will be affected? I have a colleague who's she's not in the US, she's in, I think, Belgium right now, and she's concerned about, is it Belgium or the Netherlands? One of the two, but she's basically, the health system is quite good, but she's also concerned about what happens. She's pregnant, she's 38 weeks pregnant, and is expected to possibly have a less easy or more complicated pregnancy. So is this also going to impact will COVID actually affect or impact the kinds of other forms of care that will obviously be happening? And I guess for me, that's a question that I don't know if we're at that level yet. I think I've heard from colleagues who work in hospitals in New York and Boston that they may be having some trouble if a lot of people come in at once, like what other kinds of acts that, especially at the ER. So what kinds of other emergencies or urgent care issues can actually be addressed when the hospitals are reaching their capacity. I think there are other issues as well. So people who come in for a test through outpatient or urgent care, will that also affect who is going to be, who's going to be able to be seen when they're telling you to stay home if you're sick? So there's a whole lot of stuff that actually COVID may be marginalizing other forms of care. And it may make it very difficult. And you saw this during the Ebola outbreak. So there are a lot of people who were afraid to go to facilities because they're afraid not only of becoming infected with the thing that getting infected with Ebola, but also because everyone was sort of maxed out already, handling those very intense, very complex cases. Many of our hospitals are equipped to handle sort of moderate emergencies, but I mean, actually, I'll give one more example. My father was supposed to be hospitalized last year for a heart condition, and he was he actually was on his gurney in a hallway in a private hospital with several other patients for days. He didn't even get admitted and he didn't get a room. So I'm imagining what happens if COVID hits that hospital on a normal day.
Great. Adia, the next question is, what is fundamentally unique to this outbreak in comparison to prior ones? And that's socially, politically, policy-wise.
Wow. So I would say in some ways it's unique. In some ways it's unique because it's new. It's a new disease. It's one that we don't have much precedent for. And so we're still learning. I think in other ways, it reveals some of the existing rifts in our societies, sort of our country, but also sort of globally in terms of how people move from place to place, the quality of care that's possible, the fragility of our economies, particularly when they're becoming more casualized, rooted in casualized labor. So in some ways it's unique because we're still trying to learn about it. We don't have vaccines, we don't necessarily have effective treatment, and we're not necessarily equipped to handle this if it gets significantly worse. In that same vein, we're also treating it like it's exceptional and novel. And so we're suspending a lot of things that we otherwise wouldn't suspend. And this is part of the state of emergency kind of thinking. Like, so we're exceptionalizing a lot of things. People aren't expected to go to work or which is a longer story. But we are also in this moment where a lot of our leaders are, and I'd say Trump fits into this, but he's not the only one, who are ignorant about the social repercussions of this outbreak and our response to it. So the response to it is actually producing as much strife as the disease itself. And so I would say unique because it's a unique disease and that it's new and we're still trying to figure out how to best address it. Exceptional in our response in the sense that we're willing to suspend a lot and sacrifice a lot to make sure that it doesn't spread. But what I think it's also doing is revealing a range of fault lines related to the economy, related to politics, related to the nature of work, related to how we interact and engage socially. So what does it mean to kind of create distance amongst ourselves? What does it mean to actually take a break from work and lower our expectations of the desire and the necessity of working hard every day? That's the thing. We're also learning a lot about our health system. We're learning a lot about public health, and that there isn't a bat signal and there's no hero to save us. And we need a a range of actors to be able to do their jobs. And it seems like we're not appropriately or properly equipped in ways that we should be.
Adia, there have been a number of questions sort of processing the state of Illinois in comparison to other locations around the country, both cities and states. So one piece is, you mentioned you're going to vote today, and there's been debate about whether Illinois should have canceled the election like Ohio did. Do you think it should have been canceled? Is it safe to go out and vote? And, in the similar vein, do you think Chicago or Illinois will implement a quarantine like San Francisco? So sort of just thinking about regional variations here.
Oh, this is interesting. Did Ohio really cancel? I thought the Supreme Court overturned that last night. Did I miss that or no? Okay, I'll just answer the question because so civic duty, it's the risk I'm willing to take. We also use paper ballots, so I think we're a little bit like, we don't have the screen to wipe down in Chicago at least. So I'm not worried, but one of the things we instituted was early voting, which I think helped a lot of people. We had record number of people mailing in their ballots in Illinois. So I think that's going to be a big thing. People have been working, assuring us that they're working to keep those places clean. I think the democratic process at this point is something that we should be very invested in. I do worry about whether the disease. I'm wondering if we should have actually changed how we vote and the duration for our duration of the sort of election period. But again, this is something that's somewhat exceptional. We have, so as I mentioned before, and I just learned this fairly recently, Chicago started its pandemic preparedness last year, or at least did a test of their epidemic preparedness or emergency preparedness plan. The public health department for Chicago is actually run by a person who used to be an epidemic intelligence officer. I don't know how many people knew that. It seems that the city and the state have actually been in better coordination with each other than, say, with the federal government. And I think this is where the actual structure and organization of our public health system breaks down, is we're getting very mixed messages, uncoordinated messages, and uncoordinated actual implementation at these different levels. I think that's both the strength of our decentralized model, but also a weakness, because we can have this incredible mismatch. We have a sort of federal response and a federal set of recommendations that may or may not match up with the local situation. I believe that a lot of places are undercounting. I believe that we will. I think we still have a lot to see about how well these interventions actually work. I think we still don't know how much these interventions will actually be part of the problem. I mean, a problem that may even be worse than the disease itself. One thing that I'm also concerned about, I mean, Chicago may not actually be in San Francisco's position for a range of reasons. Some of which is how we're a little bit more spread out. We have a little bit of a different kind of geography and probably as prepared public health system. How we'll deal with it. But one thing I also warned a few weeks ago was many of our social rifts, in other words, the racial class divides, especially those that we see in places like Chicago and San Francisco, Seattle, will also reveal some of the fault lines in care. And the social safety nets that we have, the social supports that we have in place. People who have been self-reliant or reliant on a strong community network may pull through this, but we also have to think about questions of like rent control, mortgages, casualized labor, public transportation, so on and so forth. I'm not sure if I answered that question completely, but I am concerned. I was very concerned when Oklahoma found 58 tests to test members of the Oklahoma City Thunder and the Utah Jazz, but we don't necessarily have tests for people who are at risk, who are not millionaires, who play professional sports. But that's another story altogether.
We've had a number of questions, Adia, about sort of how this is affecting our everyday lives, whether and how long to avoid visiting elderly family members, how we can help people in our communities, how we best communicate the crisis to children. There's some about sort of forecasting around how long we can expect to self-isolate, some about what we do as people who live in high density spaces in a city like Chicago or Evanston. So give you that range of questions to try and tackle.
That's a lot. Well, because I've obviously been thinking about this too. How long are we? I think 2 weeks is not long enough if we're thinking solely epidemiologically. The incubation period of the disease is max 14 days or something. They say, we don't even know. So these are the things we're still figuring out. But if an infectious disease modeler, I assume, given the ones I've talked to, would try to go, okay, so how long would people have to be sheltered in place to be able to stop transmission altogether? It would be, we're beyond that. Like, we can't do that. Particularly with how easily it's spread through contact. And also given the lack of testing and the number of people who have minimal sort of mild disease, or mild disease while they're transmitting it. So I think what we're facing is strict interventions that emerge when other systems have failed. We are basically dealing with what I think is the backlash of that failure to really focus on diagnostics and really focus on getting to the root of this very early on. So that's that. But I think we're also dealing with the sort of like problem of uncertainty that trickles from all the way from the top all the way down, which is to say things we don't know about the disease, but also very hesitant, somewhat ignorant responses at the federal level. Foolish even. So I'm not sure what's going to happen. I have to be honest, but what I will say, and I'm not sure that 2 weeks is going to be enough for much, unless it's just to buy time to figure out deeper interventions. So it seems like we're getting better access to tests. It seems like the national stockpile has lots of ventilators and other materials. It seems like industry is ramping up production. I have a couple of friends who work in like procurement and governments, and they say, oh, we're getting requests for manufacturers to make more medical equipment and more protective gear. So something is happening. Will it happen at the scale that we need in the time that we need it? I don't know. When it comes to our elderly and vulnerable and other vulnerable members of our communities, this is the time when our people who are skilled in community organizing, our people who are who have the means, actually have to look out for each other. So if you know people who are struggling because they don't have a lot of family or friends nearby, if you know that there are people who can't get their groceries or whatever, we hope that we could reach out. But I think there are also ways that we need to kind of tap into some of the resources that ostensibly our cities and our states had been planning for using the resources that they'd been planning to use under these conditions of emergency. So really understanding what is available to us because of this emergency and how we can best distribute those in ways that reflect, or at least are attentive to, the vulnerabilities in our community. So I know that the city of Chicago says that that was a part of their preparedness plan. It's why they were able to kind of come out with a package of interventions related to school closures. It's one of the reasons they're able to kind of advise on those issues. So many cities would have a preparedness plan like that. I just saw a video with Mel Brooks and his son. He's talking to his son through a glass door in the back of the house, and and sort of communicating that way. He drops off groceries or whatever. I think for a few days, once you realize that you're not having symptoms or whatever, you may be able to kind of start or re-engage and have those kinds of face-to-face interactions with your people again. I've been thinking about taking my kids down to see my parents, and I do have to think about my father's health and my mother's health and things like that. And so we've been talking about like what that would look like and how we would limit exposures and things like that. And I think that's just we need family plans and community plans as well.
Adia, I want to think for a minute and would love your thoughts, as would many, about the international comparative element here. Obviously we're sort of catching the tail end of this, presumably. I don't know, the mid range of it, who knows? But it's not like we're the first ones in the United States to deal with this problem. And so there have been some questions about approaching the pandemic, reactions, the ways in which South Korea has been so successful in handling the outbreak. What do you sort of make of the different responses, and what are we to learn here?
So yeah, we have South Korea, who've been sort of held up as a really good model, particularly because they didn't do, I think, as formal a lockdown as many of the other places that we're talking. So Italy's, we can't really, there are a bunch of places that we could be comparing ourselves to right now. And we're probably a little bit more like Italy, except Italy's demographically an older population with I was talking to some demographers, and I think, we talk about them not having enough replacement. So births and deaths are not even, so to speak. Singapore apparently did well. It's like one of those things where you're like, do you have to be an island nation with an authoritarian leader to be able to pull this off? Yes and no. So yes, let's talk about South Korea. One thing that South Korea did that we did not was we did not have rapid testing. We did not have immediate testing. And so in that regard, we failed. There wasn't, I think, a sort of committed and concerted effort to equip people with the materials that they needed, or I'd say the resources that they needed to be able to follow directives about social distancing and mobility. So in that regard, I think that's where we failed. And I believe that that's one, and they also have a very good health system that could handle the capacity, and they do a really, Singapore actually did a very good job of explaining what it is that they did as well, which looked very different from what South Korea did. We're trying to use some of the techniques that South Korea used, which I know everyone talks about, those drive-through testing centers. Unfortunately, ours are the story that I heard from Trump in his address is that when he declared the national emergency, was that we're getting it through Target and Walmart or something. So it's sort of a corporatized response, which I guess is what you should expect from a corporate president. I'm hopeful about those. I think we also have other concerns, which is the extent to which the emergency helps with regulatory situations. So in other words, can we get something through the FDA in time, or can it be exempted from a process? There are costs and benefits to that, right? So in some ways, we lose some of the any the safety regulations. We lose some of the benefits. So we're looking at vaccines that are being rapidly produced and tested right now. We're looking at drugs that are being repurposed for treatments and things like that. And so one of the things that I'm concerned about is, can we ensure public safety without also making us guinea pigs for a capitalist experiment? I know that sounds very paranoid, but it's something that I worry about, because it did also happen in West Africa, right? So what are we assenting to when we ask for things to happen more quickly? Of course, there are many tests and many other kinds of diagnostic modalities that are being rolled out in South Korea, in China, in Japan, in Europe. And we might, if we had actually used those and pushed those through the regulatory process, we might be in a different situation right now. That question was about what I think what we can learn is, and there's a pretty good report from the WHO from China that we could use some of their strategies while also not using some of the weird surveillance authoritarian strategies or punitive strategies. I think we can learn from South Korea in the ways that communities adapted, but also the ways that the government responded very quickly, the way that it rolled out the kinds of technologies that enable interventions and that enable non-punitive interventions. That's what I would say. I think we also need to be careful to look at what it is that our states think of, what our states actually do, and how they imagine emergency. Every state has a different kind of state of emergency and what powers are suspended under those emergencies. And they have very little to tell us about what good can be done, what things that can be done that enable care and solidarity in these moments.
On that point, Adia, we've had a question about, can you talk a little bit more about authoritarianism, and if and when this crisis ends, what do you think is the possibility that governments and militaries may not relinquish the power that they've extended over their nations?
This is a very thorny topic. The other day I was joking about how Giorgio Agamben, the Italian philosopher, who'd written about the states of exception and how governments suspend the rule of law to be able to enact certain kinds of, I'd say, implement certain kinds of laws, rules, and so on that could be damaging to a population. Let's just put it that way. He was complaining that was happening in Italy. A lot of other philosophers disagreed and thought he was being a little bit of a I don't know what's the word, hysterical. People who study authoritarianism, anthropologists particularly who study authoritarianism, are very worried that the national emergency opens up possibilities for Trump. So can you cancel an election? Can you postpone an election? Do you have even more do certain forms of force and violence achieve greater legitimacy under the national emergency? So in other words, can the National Guard, can state militaries and the federal and our US military actually act against us and against our interests, and to uphold the authoritarian rule? That's a possibility. And so that's why I'm actually urging people to think about what kinds of powers are being granted under any kind of emergency. So my friends in New York, when they heard that New York entered a state of emergency, which could mean that borders were going to be secured, they started to say, well, so what if I want to go to New Jersey or Connecticut or Massachusetts or whatever? Is that going to be patrolled? What if I get on a train that leaves the state? What does an emergency look like for every state? And what movements or mobilities are restricted through this calling something a state of emergency? And then a week later, we see that they've created a containment zone in New Rochelle. Again, I don't want to sound like paranoid, but it looks very suspicious, or it feels punitive. When I believe that once these people knew that they were sick and at risk for transmitting to others, they were willing to shelter in place and stay home. And people were aware of that sort of the contagiousness of the household, so to speak. So is this security theater or is it something else? Like, what are we normalizing here? I read another piece about a person who had a helicopter circling above and telling them to go back into the house after someone in their household had been found to be sick. And so again, these are really spectacular instances of this emergency, but you want to think about, again, what are your rights? What are your responsibilities? What is the government, what can the government do under these conditions? You want them to be able to implement interventions that are helpful and that ensure that others don't get very sick. But you also want to make sure that those powers don't just, grow blob-like, leaving you holding the bag, and leaving us, not you, us. So I encourage people to kind of become familiar with and learn about what it is that a national or a state emergency or city emergency means, what it looks like, beyond the health consequences, because the health stuff is a very small part of this.
Adia, we've had a number of questions about your particular area of expertise here, which is inequality during these humanitarian and global health crises. And so, I think many people are really concerned, as they should be, about the ways that this virus is going to further amplify the effects of inequality on our most vulnerable populations. So this particular attendee asks, one, do you have any advice for how to help in the short term? And then what can we be thinking about and doing in the longer term?
This is great. I've been trying to figure this out myself. Because like I said, a lot of wage workers, self-employed people especially, will experience shocks, especially if their work is meant to be done face to face. So, I know people who train athletes, they train people who want to stay fit and they need to be in that, can they do things online or whatever, but that stuff it's ephemeral. And so what I'm trying to do myself is, the people who I know are getting paid hourly or getting paid for doing face-to-face or care work, I'm trying to figure out ways that I can help them personally. That I can't do that by myself. But I think we have a few bills that are going through Congress right now that are supposed to be helping develop. I think one just passed last night. Am I making this up? Is it last night? I feel like this timeline is becoming very, things happened yesterday and it feels like last week. So, I think at this point, we're actually going to have, instead of bailing out banks, or in addition to bailing out banks, we need to be holding our officials accountable for how they're thinking about helping people who are in this position. So that's one way that inequality is manifest. There are others, including, so we're, one of the things that they're doing is like, oh, we're talking about the cost of a test and the cost of care. Those are, again, spectacular, in the sense that we know that a lot of people won't actually have to seek care. We need safety nets for those people who have to be in the hospital and who are admitted and all that stuff, but we actually have people for whom the disease is the least of their worries. And so, like I said, some cities say, oh, we have stuff for emergency, we have food and we have this, but I don't think that we're we're ready for something beyond 3 months. I think we probably need to start thinking too about work, the nature of work, and how we can make sure that people are supported. I hate to be the when I think about this, I feel so overwhelmed, because this is actually one of the things that worries me the most, which is the fact that the intervention itself is causing the pain. It's going to, and it's going to wreak havoc, and and I don't understand how we're not bailing out families. But this is also maybe one of these things where we need to look to other places as a model. Are these other countries that are instituting this kind of extreme social distancing, so quarantines, isolation, and so forth, are there strategies that they're using to ensure that people are cared for? This might be another place where, so instead of just looking at like diagnostics and care and all that stuff, are there other models available to us that we can sort of think through as organizers, as communities, and so on, to kind of advance this? I do think that this is going to take lots of people hanging their heads together, and lots in a grassroots movement. That's how I'm feeling right now. I go to bed thinking about this. I wake up thinking about this. I'm probably getting like coronavirus. So I probably have coronavirus at this point. I'm kidding. I don't. Of course, I can't get a test, so who knows? But anyway, this is something that actually is on my mind, and something that I hope that someone smarter than me can help us think through.
So, we have a few minutes left, and there have been a number of really excellent questions that unfortunately we don't have time for, but I did want to sort of look to the future. And we have a couple of questions in that space. And one of the key ones that we think about a lot at Buffett is, how do we think about what a global solution looks like for something like this global pandemic?
Yeah, and I love that question. I've been thinking about it a lot. And one of the ways I was thinking about it was through sports, and bear with me, because we have a few global events coming up. I found out this morning that they're postponing the Euro 2020 to 2021, so it doesn't have as catchy a name. And I had tickets to see it in Azerbaijan, which is one of these countries that's sort of ranked as like level 3, because it borders countries that have severe outbreaks. And when I thought about it, and obviously we have the Olympics in Tokyo coming up, and I think of those as emblematic of why we actually need a truly global response, in the sense that, even if Japan gets their numbers down, even if Japan stops transmission, Japan is going to be hosting millions of people who came for this game from all over the world. So they're going to have, so whatever they think they did nationally is sort of like, it's beside the point, right? It is not, and the same thing happened in Brazil, and the same thing. So what a global response means is we actually need nations that trust in international or transnational institutions, global institutions, and we don't have that right now. So, World Health Organization exists and has existed since the end of World War II for that reason. But, in the past 30 years or so, its strength, its ability to act as a global institution, I think, has waned. It sort of transitioned from a place that has aspirations to affect global thinking around health, to just an institution that sits in a sort of weakened advisory role. So I would say it would be nice if we could invest in global institutions. It would be nice if we could invest in them and understand that our relationships, the things that link us together, are not simply relations of trade. Not only relations of capital. And that's sort of, I think, unfortunately, that's sort of at the backbone of any international health regulation right now. which is what are the relations of capital that undergird the way that these kinds of organizations function. One of the things that Amitav Ghosh said this many years ago. He said that the UN is like the mother of all bureaucracies because it's like every bureaucracy joins together, and so you see the same kinds of hierarchies that exist between nations, within nations and between nations. So your elites are sent to Geneva or wherever. Your elites, and they're hierarchically organized in ways that reflect power. So I'm kind of talking around the fact that we have global institutions. We probably need to invest in them better, but we also need to reimagine them outside of existing hierarchies. We need to imagine them as institutions of solidarity, and ones that in which the entities that make it up share in common cause, and health is one of those things. It would be lovely. We're talking about something like universal health care now, and I think we need to start going back to these broader questions about equity, so fairness, about we have to really question how power functions and operates, not simply in the countries that comprise these institutions, but within the institutions themselves, in the interventions as they're implemented. I'm not sure how we do this, but there are other movements that are at work here. So the People's Health Movement, for example, try to work against the capitalist logics of the World Health Organization, so to speak. Not so to speak, they do exist, but I think I can say World Health is not really what they do. So.
Great, wonderful. Well, listen, Adia, we have to stop, unfortunately, but you've given us so much to think about, serving up some really larger questions here about how to think about the nature of work, what are the consequences of well-meaning policies for rising authoritarianism, how do we reimagine equity, and much more. And I want to thank you, but also everyone for joining us today. We were over 500 strong. And this will be a series of webinars offering new and more expansive perspectives on the current crisis. So please stay in touch with us on Twitter @BuffettInst and sign up for our mailing list, or reach out to me on email at buffettdirector.northwestern.edu, buffettdirector@northwestern.edu if you have ideas. You can expect us to receive a link to a survey where we hope you'll share your ideas also. And in the meantime, everyone, please be well and stay imaginative and hopeful. Thanks so much. Bye.
Thank you.